Hello and welcome, everybody. This is a special presentation, which is part of our Year of Healing initiative at St. John Armenian Church. It's been our objective throughout this year, 2024, to explore ways that we as a community, as a parish, can access the healing that God has designed for us and called us to when he proclaimed that the greatest law was that we should love him with all of our hearts and all of our minds and all of our strength, such that we should pursue a life wherein we are able to bring as much as we're able to bear of all of those things for the sake of fulfilling his will. And as part of that, it means finding the ways that through God's providence and through his vision in establishing through the church, through his son Jesus Christ, we can grow in health in all of its forms together. And throughout the year, we've been, searching in different areas of our community life where we can find that. We've spoken about healing spiritually through the prayers of our fathers and through the deep well of spiritual empowerment and strength that we have within our church life. We spoke about healing through grief, and our guest today, one of our guests, Diran Avagyan, joined us on that occasion to speak to us about how we can heal through grief. We spoke about healing in community. We spoke about healing through confession, healing by being stewards and part of the environment that we are meant to live in, and much more. And I wanted to continue this conversation this month in a new direction, and I reached out to both of today's guests, and I'm joined, as I said before, by Diran Avagyan, and I'm also very happy to be joined by Dr. Rafik Mughnetsyan. Dr. Mughnetsyan is a hospice and palliative care fellow at City of Hope Hospital in Duarte, California. And I reached out to him initially not because of his expertise in the field of hospice and palliative care, but because I had an idea to speak about something that's been rather in vogue lately, which is this concept of blue zones and creating an environment in your life where you can, have the sort of holistic health that we've been talking about all year long, using models from around the world where we see people living a long, healthy, happy, fulfilled lives, seeing how we can create that in our own community. And as it turns out, the conversation went in a completely different direction. And I'm happy for that because I see the Holy Spirit in the midst of us when those moments come about, that we take a radical turn that leads us perhaps not where we thought we should be, but where we need to be. And that is for us to discuss palliative care, end-of-life care, and transition. It had never occurred to me, despite the fact that as a parish priest, being a part of the lives of our parishioners during that most crucial moment where they're transitioning from life to life, that is part of our conversation about healing, that we would speak about end-of-life care. But it is truly, really relevant because there is a healing that is experienced even in that moment that we prepare to be reunited with our Lord and Savior, Jesus Christ. I'm going to turn the reins over in a second to our guests and ask them to introduce themselves for our listeners, for our audience, and to proceed with today's presentation. But I wanted to just share a brief reflection recently of a conversation that I had that brought me to kind of a deeper understanding about how we all view this idea of healing and end of life. In my community here, because of this theme for 2024, we've spoken a lot about health and healing. It comes up quite often after Badarak on Sundays. And I was speaking with a parishioner who had a career as a social worker and whose son is now a doctor in an emergency room setting. dealing with highly traumatic situations. And some of us will know also that social workers themselves are often dealing with very traumatic circumstances, and God bless them. Truly, that's its own calling. And this individual was speaking to me about somebody who is in a phase of end of life care right now and transitioning. And they made a comment to me saying, I don't know how you do it. I don't know how my son does it, being a hospital in an emergency room setting, being with people who are dying. How do you cope with that? And I took a step back and I said to her, I think my perspective is on this matter that, and I imagine, because I've never been a social worker and I've never been a doctor, and our doctor on the call today can tell me otherwise. But when I'm with somebody who's dying, I don't view death as failure. I view it as an inevitable step in the life that God has designed for us. And my goal isn't to avoid death. And I don't think that death is the opposite of health per se, because today we're talking about the health of our inner lives, the health of our soul. And, it's possible for us to be in that most vulnerable moment of dying, but still feel alive and excited for what's coming next. And I feel so blessed to be a part of that. And I don't walk away from those moments feeling burdened, or that, something, that a failure somehow has taken place in God's design. I walk away from it entrusting their souls to God's care. And often, surprisingly, in a way I would have never expected in my life, even feeling uplifted from those experiences. And so now I want to hand over the reins to our guests today. First, Diran, welcome back to our Year of Healing program here at St. John. Thank you for joining us again and doing so, with a lot of passion in your role as a clinical chaplain, who really has, I think, found this amazing vocation at this stage in your life to serve people in a hospital setting. Can you tell us more about, what it means for you to be a part of this conversation and perhaps kick off our conversation today?
Sure. Thank you, Tara. Thank you for this opportunity. And I was personally following the Year of Healing. And I have to say this, it was a very refreshing, very life-giving experience for me personally, with all the seminars and presentations and the events that you held at St. John. And I hope and I pray that your parishioners will continue to use the resources and all the materials recorded and spoken and unspoken, to utilize positively in their lives and be healed spiritually and physically, emotionally, and otherwise. Yeah. I also thank Dr. Rafik Mughnetsyan. I had the honor and privilege of working with him at Adventist Health Glendale when I was doing part of his internship. Oh, that's so good. And indeed, today's theme is very, very deep, and it's interesting, intriguing in some cases, because there are so many cultural, social, spiritual, religious, intricacies that connect palliative care in general, end of life situations, and all of their, different levels and stages. But one important thing is that death is the inseparable part of life, and it's a very mysterious thing. And we live in a culture and society that, for the most part, we avoid to use the word death. Even in Armenian language, we say menjets, and we use other words in English as well: departed, graduated, transitioned. But I think it's very important to have these conversations, because it's something imminent, something impending, and it's part and parcel of the life we live. And as you said, Teraj, rightfully, theologically speaking, it's a transition to another life, eternal life, and health doesn't really mean only physical health. It's a holistic thing. It is beyond our physical body. It transcends our physical body. So in this sense, I think our conversation is going to be very intriguing, very interesting. It might be provoking as well. So we put some slides together with Dr. Mughnetsyan, but I think we can keep it informal. It doesn't have to be a lecture, so we can just jump in and say something if we feel like doing so. But the whole point is to show the four-dimensional, healing of the body, mind, and soul, and the biopsychosocial spiritual aspect that can be integrated into this.
Yeah, thank you, Diran. And one thing I wanted to mention before I give Dr. Mughnetsyan a chance to speak is he is part of the rarefied group of highly respectable people that we can call Dr. Deacons. He is also an active serving deacon at St. Leon Cathedral. And being a little bit older than him, it's been a source of pride for me to see him grow and develop into his multiple vocations as he has. So thank you for being with us, Dr. Mughnetsyan.
Thank you, Diraj. And yesterday I actually, there was an Armenian patient who family needed a prayer. So I called, got in, and he said, you guys are at the clergy conference. But he was able to kind of send me some prayers, and then I was able to pray for the patient and pray for the family members. So I think it was yesterday I was on definitely a dual duty. It was where I was
it's just
as a doctor and also as just a praying deacon for our patient. And I'm very happy to have this talk, because to me it's always being able to, since we don't have this conversation, it's not a common conversation. We have this is a way for us to really get to know our family members, and really for us to get to know ourselves, and for us to really be able to because every person I know, just because you're Armenian, but every individual Armenian has their own kind of way of faith, the spiritual care, and the way they look at their life. And so I think we really hope that this gives a little small window for people to kind of start having those tough conversations, and also to understand that it's a tough conversation, but there's so many people that can help you with it. Your primary doctor, your social worker, your chaplain, there are people who can guide you through this. A lot of people avoid the conversations because it's tough, but you don't have to do it alone. And I think this is a great example of how people in my profession, people in Diran's profession, also like you did, then you can really hopefully get some tools to really be able to help people as they kind of unfortunately have to have those deep conversations, when a diagnosis or just a terminal disease comes up.
Yeah, thank you. That's a wonderful point. And that's certainly, I think, one of our goals today is not just to explore, the spiritual component of this experience, but also to provide some practical tools for people to demystify some of the elements of end-of-life care. I'm very desensitized to this at this stage in my life, that I often find myself speaking to family members, speaking about things like DNRs or what have you, and being surprised that, at an advanced stage, family members might not even be aware of what that would be, for example, and that's one of the elements of the process, or what hospice care is, which honestly, if I'm being some objective about it, I understand. This isn't something that people want to dive into and learn more about, but I hope people will trust us and walk with us through this journey, so that we can help make them feel a little bit more comfortable and prepared for these moments if they should arise.
Yeah, I think that's a great intention for us to set before we kind of start this presentation. Diranjan, I'll go ahead and share the screen, and then I can just go with slides.
Please. You're part of the interdisciplinary team today.
That's my honor.
Imagine you're doing grounding. in a clinical setting.
All right. Looks good, guys. Good start. Okay. So I guess the title of our presentation is just looking at the biopsychosocial, spiritual approach to just palliative care, but most importantly, just integrating Armenian Orthodox perspectives. And that's where I think Diran's approach is very important. And from my surprise, Diran added this picture, and I know it's... Yeah, so I think Diran's expertise has been well known in our community, because here at City of Hope we do have Armenian patients, and then it's so I think he was given the opportunity to give a talk to some of our palliative care team members here, just to really explain, because it's not that every year they have an Armenian fellow here, and there's we don't have an Armenian doctor on the staff. So I think Diran's approach, because now whenever I can tell you that whenever I think they have an Armenian patient, it's not necessary if I'm not there. I know that the approaches and then the thought process behind the Orthodox Church kind of has been instilled in the people around me. So they really try to respect those thoughts whenever they are talking to patients.
Yeah, so maybe let's give a little bit theological background why this is important to us. Because again, life and death, as I said, it's part of God's mystery, and without going deep into afterlife eschatology of the Armenian Church, it's important to mention that the resurrection of the dead is the pillar of understanding the Armenian Orthodox eschatology, and it's in the Nicene Creed where we very clearly read, we believe in the resurrection of the dead, in the everlasting judgment of the souls and bodies, in the kingdom of heaven, and in the life eternal. So this is a very important statement for us as Christians. Life everlasting. I think we can talk about this one.
I think we can speak about that for a second. I think we need to. I think we're honored to. And before we delve into that, and maybe for some of our lay people, I want to explain what eschatology means. Eschatology refers to the beliefs that we have around the end of times. So what is it that we expect, from the end of this epoch, and the realization of the restoration of the fullness of God's kingdom in the created world and in the uncreated world. And I think the great news there is that we have a place in that story and in those beliefs, that we belong there. This isn't the story of something that will happen to other people. This is the story of what could happen to me and to you and to our loved ones. And it's, foundational and fundamental. We reinforce this with every step that we take in our life in the church, from the moment that we're baptized until the moment that we are placed in our final resting place. We're expressing a deep devotion and belief in this truth, that we are part of that which is to come, and our eternal life is promised to us by the person who we believe has given us this life, by God Himself. And it's like the air that we breathe, really, as Christians. But often, because it's so ubiquitous and the underpinning of everything that we believe, sometimes we forget about it. We forget to think about the reality of it and what the impact and what the weight of that belief is. So I think embracing this is something deeply empowering at every stage of life, including in the last stages, especially in the last stages of life.
Right. And there, theologically speaking, it's very distinct. There is the physical death and also spiritual death. And, I like the verse from the Gospel of Luke, chapter 16. Actually, it's verse 22nd, when it says, "So it was that the beggar died and was carried by the angels to Abraham's bosom." Period. And then it continues. "The rich man also died and was buried." So Shathastagya, it's very clear, death is for everyone, regardless of your social status. It's part of life, whether you're poor, whether you're rich, whether you're smart or uneducated. It's something inevitable, it's imminent, and that's going to happen sometime in our lifetime, the physical death. But also there is a very distinct, description of spiritual death, again, in the Gospel of Luke, chapter 15, verse 24, "My son was dead, and he's alive again." So actually, this is about the spiritual death. I think that's very important distinction that we have to make when speaking about death. And speaking of eternal life, it's also important to speak about eternal healing. And I found this in Bishop Daniel Findicyan's book published by St. Nurses. It's a small brochure. The title is "A Prayer for Healing." And Bishop Findicyan actually puts in a very beautiful word, saying that, eternal healing is something that Christ restores our divine pulse, the vital sign of heavenly life that even biological death cannot extinguish. So we pray for this eternal healing. Even in God's mysterious providence, recovery from physical illness is not possible. So we pray that we can heal beyond our physical bodies. And I think it's very profound. Maybe hard to understand, but it is spiritually very profound.
Those words, profound is the right word. They take me back to a moment from my pastoral experiences that just has come to me and I want to share. When you're a young priest, I suppose, you don't know what to expect in pastoral service. You hear stories about getting, a call in the middle of the night and there's an emergency, and somebody's asking for you to come and to pray for them in the hospital or what have you. I didn't know. Would those sorts of things happen all the time? Would they never happen? Is it, just kind of more of a legend than a reality? The truth is, they do happen. They don't happen all the time, but they do happen. And one time, I remember getting a call. It was 11:30, close to midnight, and it was a call from UCSF, Parnassus campus, which, as you know, is very close to our church here. And the team there called me saying that there was a young man who was dying, and they were asking for a priest. And what was shocking for me was that I didn't know about this young man or this family of being literally just a couple miles away from the church, and being in an extreme circumstance. We're a small community here. I thought I would have known, but I didn't know. And I arrived at the hospital and I found out that it was a young man who was dying of brain cancer in his late 20s. And they had come here for a procedure from Texas. So they hadn't been in San Francisco for long. But they kind of had, one last hope in a procedure that he was going to undertake there. And they did the surgery. And unfortunately, it didn't have the effect that they were hoping for. And so by the time I had arrived, he was actively dying. And he was with his mother. And of course, his mother was very distraught. It had been a long journey for them, but she didn't expect to find herself at his bedside in that moment with him dying. And from the time that I walked in and I met them and we began praying together until he died, maybe not 10 minutes passed. It happened very quickly. And this was relatively early on in my priesthood. It was like maybe the first or second year. It's highly, dramatic circumstance. And I wasn't quite prepared for the emotional stakes. I think in that moment, things having walked into such a fresh situation and circumstances I didn't quite understand. And when the son died, it was pairing. The doctor came in and he pronounced his death. And the mother turned to me and she said, I called you because I thought you could stop this from happening. And that was a very difficult moment.
Wow, that's really
it was hard. It was hard. I was heartbroken, and we were all crying, of course, for just the loss of this beautiful young man's life and for the pain that his mother was feeling. I didn't know what to tell her in that moment. What could you say? And part of this thing that we do as chaplains, as priests, as palliative care doctors, I have to imagine, is to just be with people in those moments when they're suffering, we don't have answers. But I find myself comforted by the words that you just shared from Bishop Daniel. Don't know why it came to me in that moment. And they're the words that, I think we all needed to be reminded of in that moment. That the healing that we sought for him, we believe he received. It was the vivification, the resuscitation of his eternal life as he passed into the life to come. And that's not an empty comfort. That's a true form of healing, that I wished and I hoped that the mother could feel as well. And if not then eventually.
Thank you for sharing that story. It's truly heartbreaking to be present in such situations, but also such an awesome experience to be in the presence of God's mystery. Just be present and offer yourself, your attention, your empathy, your compassion. And that alone is a healing experience. But again, as spiritual care providers, sometimes we're puzzled, like we don't know what to say and we don't know what to pray. And I remember in one of my trainings in CPE, clinical pastoral education, my professor said, chaplaincy is not about doing, it's about being. You're not supposed to do anything. People think there's this misconception that, chaplains are, prayer warriors. They go from patient to patient and they offer prayer. But in fact, prayer is the least that we can offer. In my practice, if I visit like 10 or 12 patients a day, I might be asked to say a prayer maybe once or twice in the best case scenario. But for the most part, it's just to be with the patients and families and give your full attention and empathy and compassion and journey with them wherever the journey takes. And thank you again for sharing that story.
Thank you, Deraj.
Can we go to the next slide, Rafik? Perfect. And one of the reasons that I shared the picture from the City of Hope, meeting, again, there are so many cultural, intricacies, social intricacies that pertain to, end of life situation. And it's obvious that we live in a society and in a culture that is not comfortable with death or is not comfortable with, uncomfortable situation. And again, chaplains is about being comfortable in an uncomfortable situation. As Armenians, because of our history, we are very attached to life. and that attachment also brings forth some fears. And that's why it's so traumatic, traumatic to lose a friend or family member, and face death as a reality of life. I'm sure you guys had similar experiences.
If I may share, Diran, here, I think when it comes to Armenian patients, one of the, I think, the main role for me or the medical team is to be honest, right? So I always, if a patient is dying, the disease is terminal, I never like to sugarcoat, because false hope is a very mean thing to give patients. False hope means that you're providing them with this fake thing that they cling on to, and it's not really real, and it doesn't prepare them for a real life. And I think with Armenian patients, it's definitely, there's only a few moments where they wake up to the idea, but I can look at somebody in their, be like, hey, this patient, looks exactly like my grandma, looks exactly like my grandpa. Me being an Armenian doctor, I take care of all my patients like they're part of my family. But that being Armenian, there's this extra connection to it. And I'm telling you, honestly, your family member's not doing well. Their disease is terminal. They're dying. But families still cling on to it. It's very tough for them to really accept it. And I think in our community, maybe once sometimes when the patient maybe becomes confused and does not recognize the children or something, and then they'll be like, okay, maybe the doctor is saying something true, and maybe the patient is actually dying. But unfortunately, there's a big population, a big chunk of Armenians that will just kind of not accept that fact that this is just normal part of dying, and then towards the end of life, we can definitely do certain things for our family members that we know could have been towards their wishes or could have made them more comfortable. But I've kind of firsthand seen that kind of clinging on, which you can't fault somebody for not wanting for their family member to pass away, but sometimes, things are just inevitable. They're going to happen, but we can definitely have a little bit more control if we're to accept that fact a little earlier.
Of course, and again, it comes from our history as well, as people who survived the genocide or experienced the genocide, people who are taught to be resilient, fight for their lives and thrive. It's really hard to face with the reality of death, no matter what. Doesn't really matter how old the patient is. But as clinicians, we always talk about the dignity of the patient, and that's something that always comes up during the consults. It's not about us. It's not about the neighbors and family friends. It's about the patient. And I've seen so many times that, families want to do everything possible and impossible, go extra measures just, to prolong the life of their loved one. Sometimes it's really painful to see these things because in actuality, you see that the patient is suffering, but at least we have to give this perspective about dignity and eternal life and eternal healing so that they can understand that this is something unavoidable, this is something, imminent, this is something that's going to happen sooner or later. And sometimes it's really hard when the doctors, palliative doctors, come and talk to the family about comfort care, extubation and stuff, because again, in our culture, we think that death is something holy, it's something sacred. It is God's domain, and as humans, we cannot intervene in any way. So it's also challenging experience, and I'm sure you can add some stuff about this.
I think the question comes is I always will opt for prolonging life, because here, even though it's this very short-term thing we have on Earth, but I think we all come here with with our duties and things that we want to do, we want to complete, and we all have our checklist, right? So I will do everything to prolong life, but it has to be a life worth living, right? It has to be a patient's life. It has to be the person, okay, what is life? Life means, if somebody likes to ride their bike, if somebody likes to take care of their garden, likes to play with their grandchildren, if I know the life that we are going to prolong is going to be of that quality, of course, but some point we come into crossroads when we end up prolonging death, which is also not something that I can ever advocate for, because this person's body has come to a point, and kind of is God's calling, but we're kind of standing in a way, if we can talk in a blunt way. So there's always that crossroads that we have to kind of really discuss, and we sometimes really need our chaplain and spiritual care team members to really help us, because for some patients, they really, or family members, they really need to hear that conversation that, it's all right, if the patient's time is there, it's okay for us to just let them go to start the other part of their journey. So, and I've also seen how much that our spiritual care providers really help us during that time, because, medically, sometimes you hit a wall because they can only so much you can explain, and that's why you guys are such good part of our, team, and you need that perspective to really help some family members to really accept the idea.
I often say that, in order for God to work his miracle, it doesn't need all these machines here, It's not really an intervention. It's just giving the freedom, and the autonomy to the patient according to his or her, wishes, and giving the dignified care that we can possibly provide. If you go to the next slide, Doctor. Yeah, I put here some cultural taboos and challenges, but one of the obstacles is this familiar obligation that we all have towards our family and loved ones, and sometimes it's beyond the limits. We want to do it not only for ourselves but also for our friends and neighbors, so that they don't gossip, they don't say so and so didn't do this to save the life of his mother, father, brother, sister, So we think about everyone else before we think about the patient, and this is really, tragic, and that's why, as Dr. mentioned, it's really hard to start conversation about, DNR, DNI, or advanced directive, or POLST, whatever. But when we do it, I think it's also important to explain in detail so that they can understand, sometimes even be graphic about it. When you read like the DNR, and Doctor, I'm sure you will talk about it later on, it sounds really nice, life support, right? But people don't really understand what life support means. And sometimes when they see their loved ones with tubes everywhere, feeding tube, rectal tube, everything, and they say, this is not what we wanted for our family member. It's really hard when you approach a family member and say, hey, after a certain time, we have to extubate your loved one because they cannot go on like this. We have to put a trach, we have to make an incision. And they're like, wow, I didn't expect this to happen. So life-saving treatments and devices needs also to be explained very clearly and in detail so that they really understand what's going to happen to their loved ones. I remember actually a patient, Armenian patient, elderly lady with some issues with, catheter. And it was really painful to see her struggle and suffering, because for her to have a catheter in her body, it was equivalent to unfaithfulness. It was equivalent to
She felt violated.
being violated and ashamed and guilty. And this was really painful. This was very painful.
Yeah, and I think just to talk about what Diran said, right? I think we always, those discussions, they call it like kind of, goals of care discussions when it comes to, or treatment plans. But I mean, we always want to say is that for patients like that, treatment, cancer comes to a point where it cannot be treated, but we never stop caring. And I think it's very important for family members for us to really draw that picture for them that we never stop caring. And sometimes that helps, but the underlying very strong religious values or cultural values sometimes stops us to have those discussions. But next thing, like I think to go based off the topic of exactly what Diran started is to explain things in more detail. And I think this will also might end up in a part 2 thing where we have to talk about other things if, your parishioners want it. But I guess I'll first kind of explain. I really like this graph because it kind of explains how the model has changed now. Before, people used to get a serious diagnosis and you would get some treatment, and then towards the end of life, you just get some hospice for a little bit, right? But this is the new way of how things have moved when it comes to treating serious illness. At the beginning, when you have your diagnosis of serious illness, palliative care can be started early on, and palliative care is different from hospice care. Palliative care is a group of doctors who are specialized in treating your symptoms. Let's say the cancer doctor or whatever, you have some sort of an illness, you need some serious surgery or something, they will come and be able to address that issue, procedure medications. But because of those procedures and those medications, you're going to have some symptoms. You might have pain, nausea, anxiety, insomnia, and all those things add extra stress to your life. But research has shown that if early on, palliative care team comes onto the team, is able to help with those symptoms, it helps the healing process. It helps prolongs life, and it prolongs good quality life, So I can maybe talk in cancer setting, right? If I know that somebody has 10 rounds of chemotherapy, and that's going to span 10 weeks and then 10 weeks of radiation. For those 20 weeks, if palliative care follows them all throughout, is able to help with their pain, with their symptoms, that symptom stress being so low, they're able to tolerate those treatments and they're able to get the full benefits of those treatments. But if a patient is getting something and they're unbearable symptoms, they might not want to continue because it affects their quality of life. If I'm going to be in the bathroom, if I'm going to get this treatment that's supposed to prolong my life, but the prolonged life means that I'm just going to be in the bathroom all day. I cannot leave my house. I'm scared. There's no real quality. And then as for the definition of hospice is for patients, unfortunately, who are at a point where they have less than 6 months to live. That's what the prognosis is. We can always be wrong. It could be more or less. They can be enrolled something known as hospice care, where it could be done in the hospital, it could be done in a facility, it could be done at your home, where a team of nurses and doctors are able to come and provide you, still treating you, but treating your comfort, your symptoms. Because let's say your cancer has come to a point where we don't have any other chemotherapy for it. There's a dementia patient where they're at a point where we cannot help them. ALS patients, there's so many, MS patients. And the point is that we're at a point where you're so debilitated that we have no real treating disease treatment, but we can still treat your symptoms. And that's where hospice comes into aspect towards the later stage. But in that process, before you get to hospice, having palliative care can help you with your serious illness journey. And nowadays, hospice is also with your family after you die because they help with bereavement care, because they have chaplains, they have social workers part of their team, which is very important for, after you have passed for care that. And the most important is that advanced care planning can occur at any point, People with the analogy we always like to use is that you can draw a sand in the line or where you feel comfortable, There are people, let's say you have some sort of a lung issue. They say, you know what, I'm okay with treatments. I'm okay with the chest, this and that, but I never would like to be put on mechanical ventilation. I do not like that feeling. I've seen people during COVID who had it. That's not what I want. So we definitely draw in sand, that line, and we do everything for them in one setting. But if we've come to a point, we have to kind of really talk about the next steps.
So you said something I just want to focus in on for a second, which is the idea that even before somebody has reached end of life planning, they can think about and even apply themselves with regards to advanced care planning, right? If they've got health challenges.
One of our doctors here says anybody who drives a car needs an advanced care planning, because it basically, as I go, I have multiple slides. I will go through the different types of advanced care directive, the portions of it. You're basically having your wishes known. It's we have coworkers who, when they get pregnant and we understand the really complications of pregnancy, and they will make an advanced directive just in case who knows what can happen, So this is, you can be as young as whenever you are, just for you to, and then I think for people around you to know your wishes and who's going to be your emergency contact and all that.
If I reject,
go ahead, Diran.
Yeah, I think it's very important for the family dynamics as well, because I have seen many times when, the patient is dying or has to go through like serious procedure, and because there is no advanced directive, there is no any wishes expressed or POLST or anything, so family members like children have to make these tough decisions. And if there is some kind of tension between them, it becomes more and more complicated, because no one wants to make the difficult decision for their parent or their loved one. So I think having an advanced directive or clearly expressed wishes also release the pressure from the family. And it's very important.
Easy to have it earlier on whenever you're not so advanced into your disease, when you're more of sound of mind, where you can really think about the type of things you want.
Believe it or not, I've begun having this conversation with couples in premarital preparation. It's one of the things that we address, and even if it's not in the form of formal advanced care directives, I tell couples that they need to have the conversation of what their expectations are in terms of their end of life experience. And it's so hard for young people to comprehend that, that's appropriate at this stage in their life. But like you said, I would say if you drive a car, if you're breathing right now, you should be prepared for this. I mean, people have life insurance, for example, but they're not prepared to think through some of the things that you're proposing, perhaps because it seems to the superstitious mind to be inviting tragedy. Whereas I think what Diran said is a very important point, that what we are doing is we're empowering our loved ones to be able to care for us in the way that we desire, and to free them from the burden of having to make those decisions on our behalf.
Gerard, you mentioned life insurance, but even in our culture, talking about life insurance is an issue. Palliative care. It doesn't mean that the patient is going to die like in the next few days or weeks or months. It's just the care, or assisted living or any other facility, hospice. The point is that this is really difficult. This is tough. This may be unbearable, but you're not alone, and you should not carry all that burden. You should not, shoulder all that, overwhelmingness. There is a team that can support you throughout this journey. That's the whole point. It doesn't mean death necessarily.
Yeah, and I think one of the main things, it's always this, whenever we talk about for patients who, let's say we have a patient who's very sick, very ill, or very frail, the doctors will recommend something known as DNR, right? Which means do not resuscitate. As in an emergency setting, this person's heart stopped or they cannot breathe on their own, we just allow natural death. That means your body has come to its natural point where it's kind of done, and then we let them go. But a lot of people think that DNR means do not treat, as in once the patient has signed that DNR part, that's it. If the patient has a little paper cut, we're not going to put a Band-Aid on it. And which is not the way it is taught, right? It's DNR comes to a point is for a patient that is at a point where we know that chest compressions intubation is not going to benefit them and is going to lead to a very prolonged hospitalization and then even more this and that. It's part of my duty to recommend something that I know will not have a positive response. And I think that's where nowadays the taboo is that, oh, the doctor just wants this because no. It's my duty as a doctor to not recommend something that I know will not have a positive response based on my experience. Of course, nobody knows everything, and there's always the gray line, but it does not mean that we're not going to treat the patient. And I think this is sometimes a big factor when it comes to people or like in our community in general, or just very family-oriented communities. Sometimes I've also had my residency, we had taking a lot of Hispanic, Latino population, Catholic, and we also had that, would have this kind of communication kind of problems, but it's for us only, we always think of the patient and the benefit of the patient. I guess just a few kind of very technical things to talk about, since you mentioned DNR. So DNR, there's something known as a physician order for life-sustaining treatment, which is called the POLST form. It's if you've ever been in a hospital or your doctor's office, they'll give this to you. And I think what the main thing I would like to kind of address is, and I hope this is for educational purposes, and people really take this back to their, talk to their elderly parents, grandparents, take it back to their doctor, is that there's 3 sections to it. It's ABC. All 3 of them are separate from each other. A talks about just overall CPR, and CPR only happens in emergency settings when the patient is found down, they have no pulse, they're not breathing, and at that point, you have to initiate CPR, which is chest compressions, and then to be able to cardiopulmonary resuscitation, which includes being chest compressions, if they're in a setting for them to get intubated to protect their airway, to get oxygen to their body, and to try to bring them back to life. So this is, I think, one of the things that Diran mentioned earlier for us to explain, because we see movies, right? Just because we do chest compression and somebody's heart rate comes back, that doesn't mean, okay, they're going to just kind of scrape off and then walk out to go home. That means that there's going to be a prolonged, you have to stay in the ICU because you have to be in a hospital. This is not, you find some guy on the street and you do chest compressions, they wake up and that's it, because there's so much medical complications that come with that aspect. So it's all right for you to pick that, my 80-year-old, older grandparents can be DNR, older, and then they can still get full treatment, I know I'm DNR, but if I fall and break my hip, please take me to the hospital and get my hip fixed. But, if my heart stops, just allow natural death. And some of these wordings could be difficult for family members to swallow, but this is why you always need to have a very robust conversation. Always have another second family member with you to be able to ask these questions whenever you go see the doctor. And of course, the other section, it's usually for artificial nutrition, whether if the time comes you cannot have orally eat food, we want to have a trial of artificial nutrition. These are all questions that you have to talk to your doctor. But what I would like to say is that this is basically a a paper that if you are not around, like let's say your family's not around and you're found down in your home or somewhere, and then they call the paramedics, if this form is close by, usually it's very pink color, and we recommend patients to put it on their fridge. And you don't want emergency medicine personnel to come to your house, start doing chest compression, putting tubes and shocking you. But turns out that that's not something you wanted. So in California, these forms are filled for patients who have serious illnesses and, kept around the house, kept with them so their wishes are known whenever their family is not around and they're found out.
Doctor, speaking of chest compressions, can you explain?
Yeah, so I mean, the next few things are kind of right. So whenever exactly, yeah.
Technically.
So chest compressions means that if your heart is not beating, an external force has to act like your heart. I think for our church, when we go to camp, we teach all the kids CPR, right? So a person has to put their hands on your chest and push down close to 2 to 3 inches to get to your heart, to be able to pump for your heart to get oxygen to your vital organs, which means your brain, your lungs, the rest of your body. So it basically, for you to be able to have a good chest compression, which is about 100 beats in a minute. So you kind of have to, which it means that you have to definitely break the patient's ribs and sternum. So that first chest compression, the first few times that you kind of go on the patient's chest, it is very kind of tough because you're breaking ribs and you're breaking their sternum to get to their heart, and which is very painful. So this conversation comes into aspect if some patient, has stage 4 cancer, kidney problems, liver problems, heart problems, and all these things, that their return of good normal function is, less than 1%. To do that intervention for those people, it's a very painful way for them to die, because a lot of times you will not be able to have a good return of heart function. You will not be able to get a pulse back because their underlying person is so diseased. So this is tough discussions to have because nobody wants to think of those things. Nobody wants to hear because, do everything. But what does everything mean? They say, keep fighting. And I always will say, what are we fighting for? Are we fighting for just another day in the hospital, or are we going to fight for another comfortable day, possibly at home? So the conversations have to be put in a way, because we all come into these discussions with movies and TVs and things we've seen. Everybody has a little tunnel vision, and it's tough. So and next one, I'm going to quickly go through what advanced directive is. There's this website that UCSF clinicians have used to have advanced directive in multiple languages. So let's see. So advanced directives. Whenever you sign the form, one of the questions I like is that when can my medical decision maker make decision for me? So the point is that you would like to completely have autonomy of your own without, you can make decisions only after I'm not able to make my own decisions. And now right after I sign this form, so you can definitely pick the people who you want to make decisions for you. In the state of California, next of kin, as in your wife, your child, is not necessary. You can pick your neighbor, so you can pick somebody else. So this gives that thing. So I know with some of our, I took care of some Ashkenazi Jewish, Orthodox Jewish patients, and for them, their rabbi is their decision maker. So there's definitely different cultural aspects that comes into it.
Rafik, doctor, what would be, somebody might ask, whether it's submitting the DNR or the forms that you're referring to right now, what's involved in changing them? How do you update them or modify
So
them?
These are things that, so an advanced directive is notarized, but unless you have 2 witnesses, blood relatives who can sign the form for you. But these are things change, somebody goes to the doctor and then they find out they have some tumor growing on their liver and it's not looking good. And then the surgery is risky, this and that. you can fill out all this paperwork that, hey, you know what, if something happens during the surgery, you know, I would like not to be on machines and I would like to have a, you know, natural death, this and that. But surgery goes well and then you're recovering and then your, you know, chemotherapy works, this and that. You can easily change and then file a new form. So, you know, some of the other questions is, you know, how strictly do you want your medical decision maker to follow your wishes if you are not able to speak for yourself? And this is all kind of based on your wishes. You're okay for them at the moment to talk to the doctor, and the doctor says, hey, you know what, we just need 1 day of intubation and then the patient will be able to recover. Or if they say, hey, you know what, if the patient stays intubated, it might be prolonged. So do you give flexibility to your decision maker or not? And these are all very deep individualistic discussions that the patient needs to have with their doctor. And one of my favorite part of the form is that always is then says, so your current health, what is most important? My goal is to be as long as possible no matter what, or my main goal is the quality of life I'll have. And then the second part is also it differentiates at the end of life. Do you care about the quality of the days versus quantity of the days? You know, because at some point the doctors goes like we say we might not be able to add days to your life, but we can add life to your days. As in, if the patient wants to be at home where they can see their brand new 3-month-old grandchild, because we're not going to let the grandchild come to the hospital because of infectious risk, then we'll know that, okay, this person would have wanted a quality time with their grandkids at home versus having, you know, extra 5 days in the hospital where they're not going to be able to see their family members. So another place is always location, you know. So there's some family members who will say, you know what, if grandma dies at home, grandpa might never go home. And then it's like, it's the whole setting, or they have multiple family members, their kids at home, they will not like that. Then at that point, we can go ahead and then try to find other settings for the patient if they're, you know, imminently dying or they have terminal illness, whether to be at a skilled nursing facility or someplace else. But I always am a strong advocate of people going home because I think everybody will want to be at their home because more family members can come and they're on their own bed, they're more comfortable, they eat the food they want. It's so much more enjoyable. I guess, so one of the things is also, you know, it talks about just overall end-of-life topics. And then, so like you said, full code, whenever we talk about DNR, I guess the wording I didn't use is that the other part of it is full code. Full code, it means do full resuscitation, chest compressions, intubation, shocking, giving pressors, dialysis, all those things. But sometimes what the advanced directive allows is for people to try full code trial. Some people will say, hey, if I'm at a point, I'm okay with 5 days for me to be intubated, but if I'm at that point and I'm not getting better, I would not like to be on the machine for a long time. And sometimes some family members, when this is kind of a middle ground where they'll come, like let's say a spouse wants the other spouse to be able to try, you know, because they want to be them, but the other person says, I don't want it. But sometimes they'll come into an agreement where they're like, okay, you know, 3 days, I'll try intubation for 3 days, something like that, knowing that if I'm not getting better, I would like to kind of move towards corporate care. And these are all like very medical, technical. And then if any of your pensioners need some more clarity, time, I'm happy to, you know, be able to talk to them more about this. There's always the organ donation question. If people who have cancer, they cannot really donate their organs. And I think the question is, everybody thinks if you're licensed as organ donor, the second you die, they'll come and take your organs away. But that's not how organ donation works in America or just the world. There's only a specific type of population that we can donate their solid organs. They have to be brain dead, but the organs still have to be intact. But nowadays, people's, you know, cartilages, or there's some other organ, that body parts that could be donated. But that's just a conversation for you to have. Some people really, really like legacy projects where they like to have some of their organs donated because they know that they'll be able to assist somebody else. And that's something that usually City of Hope offers or some hospitals offer. But that's really, again, really a question that you can discuss with your family members. Same thing with an autopsy. Some people be like, hey, you know what, if I'm dying, if I'm dead, don't put my body through anything more. I don't want an autopsy. I would just like to just go and whatever I decide. Go ahead, Diran.
Yeah. I just wanted to say that I've had multiple individuals throughout the years reach out to me regarding what the church's position is on organ donation, autopsies, etc. And I don't think this is necessarily the forum to go into that in depth. But I would just like to invite anybody watching this, if they would like to inquire more, they can reach out to the church to find out.
Sounds good. Thank you. And so the question says, if illness, would you want your doctors and medical providers to tell you how sick you are and how long you may have to live? These are very, very, so anytime we have family discussions, I like to ask these questions because some people just, the way they are, they're like, hey, if I just don't want to know, or my kids know the best way to tell me, or I'm going to let my children or my spouse or my parents to tell me exactly what I want. And I like this because it just adds a different aspect to the patient's care, because sometimes you don't think about this part, but some people, maybe they don't want to hear it. And sometimes they say, you know what, I want you to talk to my family members before you tell me. So what I like about Advanced Directive is that it's a tool, but then for me, if I see that in the Advanced Directive, I'll just ask, sometimes, hey, is there a reason? And then because everybody, you have the right to know about your illness. So, but Advanced Directives are recommended for any person over 18 years old. Advanced Directives should be reviewed annually and ensure accurate contact information. And that way you can also, if you have a new diagnosis or something, you can definitely change that as well. I mean, the whole point is that approach as the preparation for the unexpected. POLST forms are most appropriate for patients. POLST forms are basically for patients who we already know have serious illness, or we know that they will not benefit from chest compressions, intubations. We're just trying to minimize any serious illness. And I think, let's see, where are we? And I think Diran will continue the rest of the conversation. But for me, I think the real details of hospice care, it's a beast of its own. And I think if you have enough interest, we can definitely discuss about that kind of in a different lecture. But I think because people have a lot of questions, and that alone can be just another hour lecture.
Well, we'll definitely be including contact information in our show notes, so people can reach out directly to us or create have need concerns that they need consultation on. But I agree with you. It needs to have its own platform so we can continue this discussion in the open and transparent way. Because of course, people should have questions about these things that impact our lives.
Yeah.
Sure. Thank you so much, Doctor, for breaking down this complex, ideas and procedures and the forms and everything. And as I said in the beginning, it's very important for our patients and their families to make informed decision. And while something on the paper may seem or sound like really nice, when you think about it, it might be really painful, just like the doctor said, chest compressions, where you have to do it on a, aged person with very serious medical conditions and stuff. Doctor also mentioned about discussing this kind of issues with family or patient. And this connects actually to our first part of the conversation, where we talked about, sin and spiritual death. And I think culturally for us, physical ailment is kind of connected to sin, and that's really difficult. I've seen patients who who just like to hide their condition. They do just hush in the family, make a chicken now for he want them. And we are here to say that we're just human beings and it's okay to be vulnerable. And it's not about sin, it's just a physical body that, it wears, and it's natural that we get physical ailments.
How often, if I could interject for 1 second, do we encounter, our beloved people who are suffering from ailments? And the question that they hold like deep within their hearts is, what did I do to deserve this? And it's such a powerful and just heavy burden for somebody to bear, to feel as though the source of their suffering are the mistakes that they've made in their life, knowingly or unknowingly. And let's be clear, this is a very it's a very delicate conversation, because truly mistakes and sin can lead to suffering in our life. It's possible for us to make those connections in very clear ways, but not exclusively. There are so many ways that, in this life we can suffer, but clearly not through fault of our own. So many ways, from our own personal anecdotes where we can indicate there are innocent people, certainly, that have suffered in this life. And we can take, for example, the life of St. Paul, who through his own writings indicated that he was not a well man, and he experienced suffering of all sorts during his life, but he was an apostle of Jesus Christ, and he looked upon his own ailments that he suffered perhaps good-naturedly, or maybe sometimes not. But he viewed them as, part of his own ministry. This was part of who I am, and it informs what I'm doing in this world, and how I connect with people, and, my perspective. So I think that, and if you want to speak to your own personal experience in this regard, I do think it's important for us to disconnect shame through suffering as often as we can, or in circumstances where there is truly, a shame or, a departure from God's will that took place in a person's life that has caused them suffering, to sit down with them honestly, and to address it, to triage that situation directly. But to not make false equivocations.
Yeah, I always will say that.
I think.
Sorry, Diran. I will always say that it's the disease that's killing the person, because a lot of the time the thought of, we're going to withdraw something, right? We're going to stop the machine. We're going to stop the dialysis, or we're going to not give this one thing to our patient. And I always say that it is not anybody's fault, because it's the disease that's causing this problem, right? This person needs this thing because of this, aggressive disease that they have. And modern medicine only has come to a point where we can help people with disease. And we really, most of the time, it's for me to really remove that guilt. And today, or whenever we have patients where we have these conversations, and if it's early enough in the disease, and I will tell the patient, I want you to, in your own words, say to your family, I want A, B, and I don't want C and D. And the time comes when you cannot make decision for yourself, and I go to your wife, daughter, husband, whatever, and I say, does he want A, B, C, or D? You can tell me he wants A and B, and he doesn't want C and D, and you won't feel any guilt, because your family member already, you're doing exactly what they wanted. And sometimes that helps to remove some of the guilt. Of course, it's still profoundly very sad, very tragic. We're talking about, their loved one's life. But sometimes that has helped to really kind of help some of the guilt to be kind of taken off of the patients' families.
Right. This is a very loaded issue, actually, and it connects to the quintessential problem of evil in theology. Why bad things happen to good people, and there is no really answer to that. But one source that we have in the Bible is the book of Job, and that's a really good example to share with families and patients. Job, who was, honest and pious and faithful person, he experienced all that pain and suffering and loss and grief. And yes, he had many questions, theological questions, spiritual questions, but those questions didn't necessarily seek answer. Just the expression of it brought a lot of relief to his life. Remember the three friends who were trying to counsel him and say, oh, maybe this happened because of this. Maybe you did something wrong. But at the end of the day, what Job said was like, please be quiet. I don't want to hear anything from you. I just want your presence. Be with me, support. I don't want answers. I'm just asking this because speaking about it just gives me comfort and peace. And
that's a very great example of the power of being able to express ourselves and to be heard. When that's really some of the most powerful medicine that we can receive. One of the things that I mentioned earlier as part of our year of healing, we deep dived into the practice of confession, which is, for many reasons, in the life of the Armenian Church, the common practice of personal confession has receded to a noticeable degree. And we wanted to destigmatize that for the people and to show them what it does, what it doesn't do, how it works, and to make people feel more comfortable to engage in that sacramental experience with their parish priest. And we have seen an uptake of parishioners seeking the confessional experience. And what I wanted to share about this is that one of the things that I found to be most interesting, and I often share this with confessors, is that for those that have never had the opportunity to express themselves about the things for which they have guilt, they will often be surprised that not all of the things which they are confessing are sins. That you will sit down with somebody, and yes, I'm a sinner. We're all sinners. We have sins to confess, but some of the things that weigh heavily on their hearts, you have this opportunity to say, I know you feel badly about this, but I need to tell you that at least on the basis of how I understand our faith and the moral teachings of Jesus Christ, I don't see sin in this thing that you should be forgiven for. And they walk away feeling, freed from the burden of the guilt associated with that. But what sort of health impacts can that have, carrying these heavy emotional and spiritual weights on our heart throughout our lives, including, for example, decisions like this. Decisions like, I had to say that, for example, I needed to sign a DNR for my father or something like this. And that they bring these confessions to the confessional experience. Well, it says a lot. It says a lot about, how we understand how we treat death and how we treat, and frankly, how we experience life as well.
Even for people who are not necessarily religious, but they claim to be spiritual, maybe they don't understand the church or the Orthodox faith, or the importance of confession as a practice. But, reconciliation and forgiveness is very important for their spirituality, regardless of their religious views. So people want to go from this life, depart this life with peace and comfort. So if there is anything to be said, anything to reconcile them with family, friends, for facts of life, they want to do it. And it's so important to be able to give this gift of empathetic listening and presence during these difficult times, and focus not on guilt, but on mercy of God. And I think that's also an important focus that we have to concentrate, because at the end of the day, they don't want answers. They just want to be in comfort and peace. This is true also for the family who, as we all said, they can experience guilt and shame and other feelings, fear, frustration, overwhelmingness, exhaustion, uh, and it's really heavy, and as we said, they don't have to carry all that burden by themselves, but we as spiritual care providers, as palliative care team, as clergy, church, community, we can all support and, really invite these people to think eternal healing and life beyond death. These choices, seen as acts of love, reduce guilt by aligning with the spiritual focus of peace and healing. And we talked about this, in Armenian. A lot of times we say "Tsavat tanem" very casually, without even thinking about its, deep context. But what it really means, it's the expression of the suffering love. And from the spiritual point of view, and theologically speaking, we see that suffering love on the poignant, image of Christ on the cross. He was suffering, yet he was doing that for our salvation. He was willingly taking that suffering upon himself so that we can have life. And a lot of times when we have to make painful decisions for our loved ones, that's what we do. We willingly and knowingly take that burden upon us so that we stop the suffering of our loved ones.
Yeah. Diran, if I may share something at this point, I think one of the things for me to have been present at a lot of kind of, final moments for some people's lives, I find sometimes they don't like to talk to each other because, we don't want to make, I don't want to make the other person, they're already suffering from the illness, I don't want to make them more sad or this and that. And I always say, now that you guys talked about it, I was like, God created everybody in his own image. So I think you just have to, sharing those thoughts and feelings would only bring you closer to the other person, and would only have you have such better memories and experiences. And if you think for a second you're protecting them by not to really being truthful and honest to them, you're really not, because you're not really reliving your true self. Because if you're sad, if you're kind of angry at that moment, I just express that with the person in front of you, and trust me, they'll understand. There's something about people who are kind of terminally ill towards the end of their life, where their life becomes so much more kind of clear to them. I remember many years ago, we had a young patient who had a couple of months to live, and he wanted to come to one final appointment before enrolling in hospice. And then that was one of a staple moments where I really wanted to pursue this. First of all, the doctor said, you realize that this man has such finite time when he's giving this 30 minutes to us. So we really have to be present for that interview. And one thing he shared, he was like, man, finally, I'm at a point in my life where all my relationships are good. My relationship with my parents are good. We've come to a point, forgive each other, be more open, communication, same thing with my partner, my friends. And it was this beautiful thing where we saw that he had finally come to this beautiful moment in his life. But, unfortunately, he has only, a few months to live. So I always like to tell family members that, to really maximize this beautiful time that you have with your family members. It's unfortunately limited time. Try to get rid of that guilt. Try to go to that confession. Share your love with your family member, because that would only make those last few months and things feel so much more nicer for you.
Right. Thank you for sharing that. Also, in my practice, when I visit patients and families, start comfort care, for instance, everyone is waiting there and they don't know what to say and what to do, and prayers seem to be the only hope. and hopes for a miracle, probably, possibly, and everyone is like sad and crying, and have this fear of uncertainty, fear of the unknown. I like to share stories, and I say, I want to know the story of your loved one. Uh, Whatever stories you want to share, you feel comfortable to share, whether it's a joke or something about the music that they liked, about anything, because their stories matter. And in spiritual care, what we call it's narrative spiritual direction. These stories, these narratives help also family during the grieving process. And grief doesn't start necessarily after the death. It starts way before the person is gone. And it is natural that sometimes people will react like in ways that may seem inappropriate. But again, we have to understand that people respond differently to grief. Some people might be angry, some people might be anxious, some people might be scared. But once they realize that you're honest and sincere and you want to connect with them, I think there's the breaking point for them to be vulnerable, to trust you and share with their stories, and kind of try to do the grief work together, even before the death. And it's such a fulfilling experience to be present during those times when people share through tears and laughter, and they forgive each other. They start talking about issues that was kind of was pushed under the rug for many years, but now they feel comfortable finally to bring those up and do it in a very amicable and loving and caring manner for the sake of their loved ones. So again, I think we discussed this part about guiding families for end of life decision. And thank you, doctor, for really graphically explaining these things.
Yes.
So that our listeners, our viewers can understand the details of end of life situations and make very informed decision. But one important thing is that we as clinicians, spiritual care providers, doctors need to honor traditions and cultural values that people bring for them. For instance, in our tradition, a lot of people request Holy Communion, right? Just like in the Catholic Church, last rites. And sometimes we know that patient might be MPO, especially in the ICU. They're intubated. They cannot really receive the Holy Communion. But this is something that is part of our tradition and church teaching. We cannot give the Holy Communion, of course, for very known reasons, but at least we can, partake in that sacrament in different ways, just maybe making the sign of the cross or giving the Holy Communion to the family member, but never taking that away from the patients and their families, because it's a significant thing. Like I know in the Indian culture, it's very common to give a spoonful of milk to the dying person. Again, if the person is intubated or MPO, you cannot do that. But there are certain ways, pastoral approaches that you can utilize to make that happen, but in different form and shape. You know what I mean? And I'm sure you had that experience in your ministry as well. Shulterun gudak, like it's like we make the sign of the whole.
At that point, it's appropriate and honestly more compassionate to offer the Eucharist to their lips and to discourage them from swallowing it. Some might be able to swallow it, but why risk the chance that somebody would choke on that? Instead, we do have this already ancient approach of dealing with ailing people who are seeking to participate in the sacrament. For example, the tradition of Mass, We have this thing of, we know there are people that can't come to church on Sunday because they're sick. They want to be there. They just can't be there. So we've built into our ritual this means by which we make them a part of it, so that we all receive, every single parishioner is empowered to receive a piece of this remnant of the divine liturgy, this piece of bread, and to distribute it to all of those people that couldn't be there that day, because they're still a part of what we're doing, regardless of where they might be physically or in terms of their health. And even just to hand that to a person, even if they can't eat it, means, you're a part of us and we're a part of you. We're together. And it's a beautiful sentiment. So one of the things that we often do is we sing together in the hospital rooms. And they can or cannot sometimes sing along, but it's just a moving experience. They appreciate the emotional release, the call back to the hymns that they find to be comforting and healing from their life in the church, that have both spiritual and cultural resonance. And it just feels somehow like you're united with something bigger in those moments. And we're treating the soul, right? We're not treating the body in that moment, but there is a healing that's taking place.
Right. And it's all about honoring the tradition, giving the respect and the dignity they deserve and they want it in different shapes and forms. It's, again, very important to have this pastoral sensitivity and also flexibility, just to help and elevate those values that are important for patients, regardless they're Christian or non-Christian, whether it's implicit or explicit spirituality or cultural tradition. Like if a patient like Frank Sinatra, and it was their wish, to have Frank Sinatra's music during their end of life, we want to honor that. That's the whole point, whatever they wanted, I oftentimes encourage families to bring items that have sentimental value to them, whether it's a family picture or something. Anything that would make that situation, that space, a healing space, a homey place for the person and family to be comfortable. And of course, I cannot stress the importance of collaboration with the doctors, ICU doctors, palliative care doctors, respiratory therapists, especially during comfort care, when they have to come extubate, you want to explain this to the families. Some members like to stay in the room. Some people don't feel comfortable. So accompanying them in the hallway while they extubate their loved ones and explaining that, death doesn't necessarily happen right after the extubation. We never know. We're just witnessing to this mystery together and just be there to give that support and care that they possibly may need. And of course, the bereavement consultations that can follow up. But to sum up this conversation, again, it's all about the whole person, healing the whole person, the biopsychosocial spiritual model that we can incorporate in our respective disciplines, whether it's spiritual care or medicine or psychology. We are created in the image and likeness of God, and we're not just physical bodies, but we have a soul, and we have mind, and we have heart, and it is very important that we see the whole person and we treat the whole person so that we can provide holistic healing to the person. And I think with this we can conclude our conversation. And if there are any last minute, ideas and things, we can talk about.
Yeah, no, and I guess for me, it's the importance of explaining the situation to the family members, but to me, it's always being very honest and just telling people that, death is also part of life, and it is not something that we, of course, that means we're going to miss our loved one. There's going to be an empty chair during Thanksgiving dinner. And, but to be able to provide people with comfortable death that I've seen in my practice has been very fulfilling for me, where you can really respect somebody's wishes. I've had a patient who during holidays time where their wish was to get home. If that means I need to stay a few hours extra, make sure everything they can go home.
Yeah.
That's what had to be done. So, and I think to me, one thing, but this all comes down to maybe if people ever want to tell me why I went into medicine, why into palliative care. And I always reflect back to Hovnasser Kazan's words. One time during Christmas when he does like this intimate dinner with the deacons at his house, and he always used to say, if you love God, you have to love everybody. So like you can't pick and choose. So I think that made me becoming a doctor the easiest job there is, because it's just because you work with everybody and then all the family members and this and that. So to me, I always lean on that thing in the back of my mind whenever I have a tough moment or, just things are not going well. That really helps me. And also, since I have the opportunity, I distinctly remember the day when I got ordained, and we were at the church and at the diocese, and I just remember being in the back because we're all trying to check, names, and then it landed right between, the way it happened is it landed right between Dervo or me out. Nobody can check their phone, but I remember going in the back, and then there I said, oh, Mesrop. Okay, it's Mesrop. All right, so it's going to be there, Mesrop. But then the 40 days where he would come and initially with the pastoral, you would do some patriarchs with us at the church. Those were just such special moments, this basically brand new newborn priest. And then out here trying to do services, that were just some great memories.
I was a lady priest. But that was a live streamed Badarak.
I know, yeah. It was like
40 live. Well, I want to thank both of you for this time that you've shared with us. Honestly, I can tell you, I really, truly believe this is going to be a benefit to many of our community members. And it would have been a benefit to a younger me who didn't know or understand any of these things at a certain point in my life. And I'm praying for you in your vocations. I think you have, by the grace of God, arrived in the places where you belong, and you are doing work that glorifies Him, for which I'm grateful. So on behalf of our community, thank you again, and God bless you both.
Thank you.
And as we wrap up this recording, as we wrap up this session, I want to remind all of our listeners to please reach out if you do have questions regarding these very serious topics that we discussed today. It is safe for you to talk to us about these things, and there's confidentiality if you seek it, and there's nothing that you can't ask if it is weighing heavily upon you. We just invite you to reach out and to share with us what's on your hearts. And with that said, we pray that by the power of the Holy Cross, in all the ways that He grants it to us, that we be healed in this life and for the next. Amen.
Amen.